Today, with the help of this video, we'll see how a posterior capsular tear occurs during aspiration of subincisional cortex, which is so infamous for causing a posterior capsular tear at the point when it is being aspirated. This is one patient who was to be operated for visually significant cataract, and this is the fundus photograph, which is absolutely normal. And we will fast forward to the point where there is a subincisional cortex which is to be aspirated. Now watch, what happens is the surgeon is trying to aspirate it, and in this event the probe is being withdrawn out, and this causes the irrigation ports to be choked because they are in the incision, and at the same time aspiration is going on, so posterior capsule comes up and is aspirated and caught, and then there's a PC rent. So you'll see that again in slow motion, and we can see the shallowing of the anterior chamber because the aspiration port is still inside and working, and the irrigation ports are in the wound which is choked, and so the irrigation is not coming up. So the posterior capsule is elevated and is aspirated in the aspiration port, and this causes a tear, and we can see a strand of vitreous following it. So how to proceed then, because most of the cortex has been aspirated out, so one has to clear the vitreous as much as possible from the wound and sweep, using a dialer, sweep the vitreous which is bridging across into the wound and place the IOL in the sulcus as planned. It's a small PC rent, so it will not bother the centration or stability of the IOL. Now IOL, once the leading haptic goes into the sulcus, the trailing haptic also can be dialed into the sulcus, and we can see the IOL is nicely centered and in place. Now once these things are completed, then one can simply again reassure that there is no vitreous. In case there is a vitreous strand in the wound, one can use a dialer to sweep, and one has to cut so that it doesn't push the IOL away, and more so it is not there in the wound, so that there are no compromises in the long term. At the same time, it's better not to irrigate, aspirate the viscoelastic, because that will hydrate the vitreous and will cause more prolapse. Instead, fill the anterior chamber with air so that the vitreous is pushed back and the IOP is restored, so that the wound is self-sealing wound is working. So the surgery has been finished, although this was an event which was not a desired one. This is the day 1 post-op picture. We can see the slight peaking of the pupil with the air bubble in place, IOL is well centered, and the chamber is well formed. This is the day 7 picture, which is apparently better, and the pupil is absolutely round. The mydriatic will be stopped since then, and then at day 30 we can see the pupil is absolutely fine, no peaking, and the patient has visual gain, which is good. Thank you.